Welcome, my friends, to my favorite topic, that is neoplasia. Invariably, you are going to diagnose many patients as having cancer. So, as a pathologist, how we are going to make a diagnosis? What are the criteria by which we call the tumor as a benign tumor and how we call it as malignant tumor? What are the prognostic indicators of a tumor? What are the tumor markers? What are paraneoplastic syndromes? So all these interesting points are there to learn in a chapter of neoplasia. And more than that, the complicated issue like molecular basis of a cancer, how the cancers will start, how the pathogenesis will take place, how they evolve totally into a highly aggressive form, so that we see. Along with that, we also see the tumor suppressor genes and their role in a regulation of the normal cell cycle. So let us have a look how we name the tumors. What is the naming ceremony? We call it as nomenclature of tumors. Neoplasia is the word that has been derived from Greek. So neo means a new growth. Neoplasia means a new growth. The study of these tumors, we call it as oncology, and we call them as oncologists. So oncos means a tumor. When you use the word cancer, it always means a malignant tumor. Cancer cannot be benign. So cancer word has been derived from a crab. Like a crab, once it catches, it doesn't leave easily. So similar way, it was the initial concept that once cancer is there, patient is going to die definitely. That was the concept. So that's how the word cancer has been derived. But when you use the word tumor, you should be very careful. The tumor word, it refers to both. It could be benign tumor, absolutely benign tumor, not at all harmful, or it could be malignant tumor, which is more aggressive. The definition, the Rupert Willis definition, is the best definition of neoplasia. It goes like this. A neoplasm is an abnormal mass of a tissue, the growth of which exceeds and is uncoordinated with that of a normal surrounding tissue, and persist in the same excessive manner even after the cessation of the stimuli which evoked the change. At the end of the learning of neoplasia, you will come to know that it is so much true that Rupert Willis definition holds good. Every sentence, every word is important in this particular definition. So it is abnormal mass of a tissue. Always tumors are abnormal. There is nothing like physiological tumors. The growth of which exceeds and uncoordinated. It is all uncoordinated continuous proliferation of cells with that of a normal tissue. If you compare to the normal tissue, the tumor cells are growing, the growth is exceeding, and it is very much totally uncoordinated way. Once the tumor is started, it persists in the same excessive manner. The growth rate will not come down even if you remove the stimuli. For example, even if you stop smoking, once the tumor is there, the tumor continues to grow. So it persists in the same excessive manner even after the cessation of a stimuli which evoke the change. You can simply define neoplasia as 4 P's: progressive, purposeless, pathologic, proliferation of cells. Progressive. There are very, very few tumors which are known for regression, some of the blastomas. Apart from that, most of the tumors are progressive in their nature. Purposeless. It doesn't do any good purpose for the human body. There is nothing, a good benefit we are going to get with a tumor. So it is a purposeless. Pathologic. It is always pathological entity. There is nothing like physiological tumors. Proliferation of cells characterized by loss of control, that is uncontrolled cell division. So you can also define neoplasia like this. It is a disturbance in the cell proliferation. It is a disturbance in the cell differentiation. It is a disturbance in relation between the cells and their surrounding stroma. So these definitions may appear quite complicated to you at this particular point, but at the end of learning the neoplasia chapter, you will come to know all these aspects. Especially when you learn about molecular basis of neoplasia, all these definitions you can understand and you can digest them easily. Why we have to study about tumors? Because 1,500 patients will die every day because of the cancers. So by 2000, WHO has estimated that around 10 million new cases of cancers are detected every year, and around 6 million deaths will occur. Which is the most common tumor in males? At present, it is the lung carcinomas because of habit of smoking, followed by prostatic carcinomas, colorectal malignancies, leukemias, lymphomas, and urinary tract carcinomas. In females, it's again, they have also started smoking. So lung carcinomas are again outstanding in number, followed by breast carcinomas, colorectal malignancies, leukemias, lymphomas, and pancreatic tumors. But this incidence, it varies from country to country. For example, in India, in females, most common carcinoma is the cervical carcinoma, uterine cervix carcinomas. Whereas in American setup, it is the breast carcinomas. So it varies from country to country. Let us have a look how the pathologist is going to sign a report as benign tumor or sign a report as malignant tumor. What are the criteria what we use while reporting a tumors? What are the criteria which will help the pathologist to define as it is a benign tumor? If it is benign tumor, which type of benign tumor? If it is a malignant tumor, which type of malignant tumor? We will take a hybrid of criteria, not only one strict criteria. We use the histogenesis, that is from which the tissue is originating from. What is the basic parental tissue from which the tumor is arising from? Embryogenesis, what is the precursor cells that are giving rise to this particular tumor? Biological behavior, is it benign or malignant? Based mainly on the biological behavior, benign tumors are very good, malignant tumors are very, very bad. Some of the tumors have been named with the name of a scientist, eponyms. We also take into criteria the gross findings, microscopic findings, and also the site of origin. So most of the time we club a hybrid of these criteria, most important being the histogenesis. What is the origin? What is the parent tissue that is giving rise to the tumor as such? So all the tumors will have a suffix oma. For example, lipoma, fibroma, carcinoma, sarcoma. So they will end up with the suffix oma. So whenever you see the suffix oma, you should think that it could be a tumorous condition. Based on the biological behavior, we classify the tumors into two things: benign tumors and malignant tumors. Benign tumors are very soft, they are very good, they takes a very, very long time to develop, and they will not cause much harm to the patient. Malignant tumors, by contrast, they are very worst, they are very aggressive, they are very rapidly growing. So malignant tumors, invariably they will have very bad prognosis on the patients. Depending on the histogenesis, we classify the tumors as epithelial cell inversion, for example carcinomas, mesenchymal inversion, for example sarcomas, germ cell tumor origin, that is mainly the blastomas. So we also take most important criteria is the histogenesis of the tumor. Let us have a look some of the examples. You have to take into criteria the tissue of origin, then add a suffix oma, then it gives the name for that particular tumor. For example, if the tumor is arising from the adipose tissue, adipocytes, we call it as lipoma. If the tumor is arising from the skeletal muscle fibers, we call it as rhabdomyoma. If the tumor is arising from the smooth muscle cells, and if it is a benign in nature, we call it as leiomyoma. If it is a tumor arising from the bone tissue, we call it as osteoma. If the tumor is arising from the cartilage, we call it as chondroma. The tumor arising from the nerve sheaths, we call it as schwannomas. So what you need to note here is, we always take into criteria what is the tissue of origin, then we'll add a suffix oma to name a tissue. It is appears very, very simple, right? So now you can try yourself. For malignant tumors, again use the same criteria, take a tissue of origin, but if it is a mesenchymal origin, add a word sarcoma. For example, lipoma is a benign tumor. So what is the malignant counterpart of lipoma? The tumor that is arising from the adipose tissue, liposarcoma. It appears very simple, right? Skeletal muscle tumor, benign tumor, you know it is a rhabdomyoma. Sarcoma is the malignant tumor counterpart, rhabdomyosarcoma. Similarly, smooth muscle tumor, leiomyoma is the benign, leiomyosarcoma is the malignant counterpart. Bone, osteoma is the benign, osteosarcoma is the malignant counterpart. Cartilage, you know, chondroma is the benign, chondrosarcoma is the malignant counterpart of the same tumor. So it appears very simple that mesenchymal tumors will have a sarcoma. So you have to take into criteria the tissue of origin, and you have to add a suffix sarcoma for that. The epithelial tumors, if they grow in a finger-like projections, we call them as papillomas. For example, squamous papilloma arising from the squamous epithelium. If it is arising from transitional epithelium in the urinary tract, we call them as transitional papillomas. If it is forming a glandular structures, we call them as adenomas. Most of the time they are cystically dilated, we call them as cystadenomas. very commonly seen in the ovarian tissue. For malignant epithelial cell tumors, we will add a suffix carcinoma. If it is arising from squamous cells, we call it as squamous cell carcinoma. If it is arising from the glandular epithelium, we call it as adenocarcinoma. If it is arising from transitional epithelium, urothelium, we call it as transitional cell carcinoma. It is as simple as that. So you have to always take into criteria what is the basic parent tissue that is giving rise to the tumor. Add a suffix carcinoma if it is arising from the epithelial in origin. So this is diagrammatical representation of the same adenoma, which is composed of benign gland forming tumor, and tumor derived from the glandular tissues. So adenoma, cystadenoma. If there are tiny finger-like projections, we call it as papillary cystadenomas, very commonly seen in the ovary again. They are benign surface epithelial cell tumors of the ovary. So wherever you see the squamous cells in the body, there you can expect squamous cell carcinomas. Right? Starting from skin you have stratified squamous keratinized epithelium. Here you can expect as squamous cell carcinomas. Your lip, oral cavity, the oropharynx, the tongue, the esophagus, all are lined by squamous epithelium. So that's why you can expect the most common malignancy among these areas is the squamous cell carcinomas. Uterine ectocervix is again lined by stratified squamous epithelium, whereas endocervix is lined by columnar epithelium. So that's how in uterine cervix, squamous cell carcinoma is very common again in females. If it is arising from endocervix, then you have to expect the adenocarcinoma. Sometimes you can see both adenosquamous carcinomas in the uterine cervix. Lung, it is not squamous epithelium, but it is a pseudo-stratified ciliated columnar epithelium. But in smokers, there will be a squamous metaplasia. Continuous smoke irritates the respiratory epithelium, so pseudo-stratified ciliated columnar epithelium will be itself undergo metaplasia into squamous epithelium. So that's why in smokers you will commonly get squamous cell carcinoma of the lung. Or the penis also you can get squamous cell carcinoma. So remember, wherever you see squamous lining, you can expect a squamous cell carcinomas. So classical example of squamous cell carcinoma of the penis. This is a microscopy diagram. This is adenocarcinoma that is arising from the intestine. So this is arising from the glandular epithelium. So what are the sites of adenocarcinoma? Wherever you see glandular epithelium, you can expect adenocarcinomas. For example, throughout GIT except esophagus, it is lined by, except even in the lower end of anus, at the anal opening. So entire GIT is lined by simple columnar epithelium, the glandular epithelium. You can expect adenocarcinomas like in stomach, intestine, small intestine, large intestine, very commonly colorectal area. So you can expect the adenocarcinomas. Gallbladder is again lined by simple columnar epithelium. So there also you can expect adenocarcinomas. In lung, you can also see adenocarcinoma formation, especially in non-smokers. Kidney, again you can expect adenocarcinomas. Renal cell carcinoma is nothing but a type of adenocarcinoma. Wherever you see urothelium in the urinary tract, you can expect a transitional cell carcinoma. So in the renal pelvis, in the ureter, in the urinary bladder, you can see the transitional cell carcinoma formation. Sometimes there can be a dual tumors, combined tumors. We call them as adenosquamous carcinomas, a combination of adeno as well as squamous. Sometimes it could be a combination of epithelial and sarcomatous component like carcinoma plus sarcoma. Very, very rare as such, but still very much known entity, carcinosarcomas. So they are very, very aggressive in nature. So this is an example of carcinosarcoma. Here is the carcinoma component. This is the sarcoma component. So combination of epithelial and mesenchymal tumors, carcinosarcomas. Some of the tumors are embryonal inversion. That means they are arising from the primitive tissues. We will add a suffix blastomas. So these blastomas are very common tumors in the pediatric age population. Very, very rarely we see in the young adults. So whenever we use the word blastoma, think that they are germ cell in their origin. So we have a germ cells in various portion of our body. If it is arising from retina, we call it as retinoblastoma. If it is arising from the kidney, we call it as nephroblastoma, nothing but Wilms tumor. If it is arising from the sympathetic trunk, we call them it as neuroblastoma. If it is arising from the kidney, we call it as hepatoblastomas. If it is arising in the brain, we call it as medulloblastomas. So remember, all these blastomas are very, very common tumors in the pediatric age population. All these blastomas appear the same under microscope. They are composed of small blue round cells, so they appear something like this under microscope. You need to know what is the site of origin. Unless you know the site of origin, all blastomas may appear same, and you may need to do variety of immunohistochemistry stain to confirm a diagnosis. Certain tumors will carry the name of a scientist who described them first. For example, Burkitt's lymphoma. It's a Dennis Burkitt who described the tumor first time in African kids. So we call to remember his name, we call the type of non-Hodgkin's lymphoma as Burkitt's lymphoma. Ewing sarcoma is again very common bone tumors in pediatric and even elderly people. We call it as Ewing sarcoma. Kaposi sarcoma is very common angiosarcoma that is seen nowadays very commonly in HIV infected patients. Hodgkin's lymphoma, again a type of Hodgkin's disease as such, in the name of Thomas Hodgkin, who described this particular entity first time. Wilms tumor, nothing but nephroblastoma. Warthin's tumor is a tumor arising from the parotid gland, very commonly seen in the smokers. Graves' tumor, nothing but renal cell carcinoma of the kidney. So, in the name of a scientist, we try to remember these names. Krukenberg's tumor, very peculiar tumor. It is mainly gastric carcinoma that gets deposited in the both side of the ovaries with a bilateral involvement of the ovaries. We call it as Krukenberg's tumor. So, these are the example of eponyms. There are miscellaneous tumors like teratomas. As the name indicates, teratoma, they are the tumors where the tissue component is derived from all the three embryonic layers, ectoderm, endoderm, and mesoderm. So the behavior of a teratoma, most of the time it is benign, but it can be even malignant also. So mature and immature. Mature is the benign, immature is the malignant counterpart. Most commonly these teratomas are seen in the ovary and testis, but they can occur anywhere in the midline. So this is a classical example of a teratoma of the ovary. You can see that hair bolus is there, along with that pultaceous material is there. We call also it as dermoid cyst of ovary, because very commonly it is lined by stratified squamous epithelium like a skin. So this is a section of a teratoma showing the skin and its adnexal structure, adipose tissue. So anything you can see in the teratomas, any tissue, ectodermal derivatives, mesenchymal derivatives, you can see the cartilage, you can see the glandular epithelium, you can see even the brain tissue. So any tissue you name, you can see in the teratomas for that matter. So last we will see some of the names which appears like a tumors, but they are not really a tumors. For example, hamartoma is the word which we use for abnormal or erroneous proliferation of a normal tissue found in that particular area, but in excessive quantity. For example, hemangioma. Beneath the skin we have blood vessels, right? But if these blood vessels are in excessive quantity, it forms a hamartoma, like a hemangioma. Capillary hemangioma, nothing but it's a localized proliferation of the blood vessels. So it is a error in the formation of a tissue. That is hamartoma. Best example is the hemangiomas. Whereas choristoma is the word where we see heterotypic tissue. That is collection of a normal tissue but at the abnormal anatomical site. For example, whenever you see gastric tissue in the Meckel's diverticulum, that is an example of choristoma. So remember, these are not true tumors but present like a tumor-like conditions, and clinically they mimic. Last, you have to remember some of the misnomers by which you can, many times while answering the MCQs you can be misguided. Lymphoma, benign or malignant? Remember, always malignant. But suffix oma is there. By just seeing oma, you should not get it confused. Lymphoma are the malignant tumors of the lymphoid tissue. Leukemia, again malignant. Hepatoma is the word. The correct word would have been hepatocellular carcinoma for the malignant condition of a tumor arising from the liver, but we still use the word hepatoma. Better word would have been hepatocellular carcinoma, but remember this is a misnomer. Melanoma, very, very common tumor of the skin, but better word would have been melanocarcinoma, but commonly we use the word melanoma and we are not removing this word from the literature. Melanoma is never benign, it's a malignant. Seminoma, benign or malignant? It is always malignant tumor of a testis. Mesothelioma, again the tumor arising from the mesothelial lining of the pleural and pericardial cavities, again malignant tumor. Myeloma, tumor of the plasma cells, again malignant tumor. Glioma, always malignant tumors of the glial tissue of the brain. Meningioma, benign or malignant? You cannot easily tell. It all depends on the location. It could be benign or it could behave like a malignant depending on where it is exactly located. So these are the misnomers which you need to remember. There are certain entities which will end up with a oma, but they are not tumors. For example, granuloma is nothing but a formation of a granulomatous lesion. It appears like a tumor-like lesion in the brain. For example, tuberculoma in the brain. It appears like a benign tumor as such, but it is not a true tumor. Tuberculoma. Understood? So there are so many conditions which will end up with a oma, but really they are not tumors. So these are the criteria what pathologists will use for naming tumors as such. Thank you.